Hello, everyone. Good afternoon. I would want to especially welcome each and every one of you to today's CPD live event. We kindly ask for 5 more minutes before the program starts. So kindly have patience with us. So 5 more minutes. So it starts exactly at 4:10. Thank you so much. Hello, everyone. Good afternoon. I would want to specially welcome you to this live CPD event on navigating hemorrhoidal disease, integrating the pharmacy and the surgical perspective, which is organized by Sevier. So I'm Samuel Kwabneji. I'm a pharmacist and I work with Sevier as a key account manager. I'm your moderator for this afternoon. Okay. So the resource persons this afternoon are Dr. Mohammed Nabil Niama and then Dr. Mark Kwame Jadosi. So Dr. Niama is an MD and a fellow and a general surgeon and a hepatopancreatobiliary consultant at the 37 Military Hospital, Accra, Ghana. He's one of our facilitators. And then also Dr. Mark Kwame Jadosi is a pharmacist with clinical pharmacy specialty and a lecturer. And he's the head of the pharmaceutical services at the International Maritime Hospital in Tema. So we would need your attention as Dr. Niama begins this presentation. There'll be an avenue for questions after the presentation, so you could kindly note down your question and then when it's time, you send it for us to read for the facilitators to answer them. Thank you. Okay, Dr. Niama, thank you so much for your time. So you can kindly proceed.
Thank you very much. I need to upload the slides. Good afternoon to everyone. Just hold on a second. Let me upload my slides. Right. Good afternoon. I hope everyone can hear me. Good afternoon and welcome to this today's program. As mentioned already, today we're going to be talking about hemorrhoidal diseases with respect to the pathophysiology, the symptoms, and the management. I think we would first and foremost start with a case presentation. Here we have a patient at the age of 35, a male patient who presented with bleeding per rectum for the past 2 years that has resulted in generalized weakness for the last 3 months. Patient has had this intermittent bleeding per rectum for the past 2 years. Now, he said that the bleeding is mostly noticed after defecation, and he sees the blood on the toilet seat, and sometimes it splashes on the toilet, what they call a bowl as well. The blood is mostly bright red in color, but sometimes he noticed certain clots in the toilet paper or in the toilet seats as well. Now, he saw a traditional healer who recommended some herbal concoctions which he used orally, and then sometimes too he has inserted some of them per the anal canal. But after using this concoction for a while, the symptoms did subside. However, symptoms had always been coming back within the last 2 years. At the same time, he's also been having some bouts of diarrhea as a result of the use of these what they call herbal concoctions. Now, after he resorted to the traditional medication and it didn't work, finally, he noticed that whenever now he sits on the toilet seat, he sees some protrusions or some swellings protruding from the anal canal. And these swellings progressively has been getting bigger and bigger. So he later presented to a GP at a private clinic after noticing he was gradually becoming weak with spells of dizziness. On direct questioning, there was no pain associated with the bleeding, with the exception of the diarrhea that he had with the use of the herbal concoction. He doesn't really have any any bouts of diarrhea, nor has he been having any serious constipation, symptoms. There has been no weight loss. Generally, he doesn't feel any sense of incompleteness when he moves his bowel, and then there are also no, what you call symptoms of palpitations. However, he feels a little bit tired mostly when he does something, particularly when he tries to do any, manual exercises. He gets tired very easily, and although he doesn't have any symptoms of, constipation, sometimes he normally strains a little before he's able to move his bowel, and the stools are mostly a little bit firm but not hard. In his past medical history, he doesn't have any chronic disease. He has no previous surgeries and was slightly obese. His body mass index was around 32. Family history: he has two brothers, one sister. Father and mother are still alive. Father and then one elder brother has been diagnosed with hemorrhoids in the past, and the father has been treated medically, while the brother has had injection sclerotherapy as one of the treatment modalities for hemorrhoids. Now, in his social history, he lives in Accra with his parents, not married, and is working as a shopkeeper. He doesn't smoke nor take in alcohol. When he came on physical examination, the vitals were mostly stable. The pulse was 82 beats per minute. BP was normal. His respiratory was normal. His oxygen saturation in room air was around 96%. However, the patient was slightly pale, but not jaundice. He was conscious and alert, and the cardiovascular system was mostly, normal. His pulse rate and his pulse volume were normal. His heart sounds were within normal range. There were no murmurs as well. His respiratory system was also basically normal. The abdomen, virtually normal abdominal findings. Now, his perineal examination, the anal hygiene was good. There were no external hemorrhoids. However, there was a protrusion from the anal canal when you ask the patient to strain. When DRE was done, the anal sphincter was of normal tone, and then we could palpate some swelling within the anal canal when digital rectal examination was done. However, no stools were palpable in the rectum, and the examination finger was stained with normal stools. So after the history and the physical examination, we made a provisional diagnosis of second degree hemorrhoids with differentials of anorectal polyp, diverticular disease, colon, or colorectal CA. Patient was asked to do a protosigmoidoscopy that identified internal hemorrhoids and nothing else. So we arrive at the definitive diagnosis of second degree hemorrhoids. That is our case presentation. Right. So now we will move on to our main presentation. That is the pathophysiology of the hemorrhoidal disease.
Hi everyone. We currently have a challenge with our internet, so kindly hold on for us. Dr. Nyama will be with us shortly. Thank you so much. I'm sure some of us will have questions already from the case study that was presented. So kindly leave your questions and comments in the chat box. After the presentation, our facilitators will answer them accordingly. Thank you so much. Dr. Nyama, welcome back and kindly proceed.
Thank you very much. Sorry for the short interruption. All right. So after the short case presentation, we move on straight to the pathophysiology and symptoms of hemorrhoidal diseases. Um, the scope of my presentation will be we need to define what hemorrhoids are. We'll talk briefly about the epidemiology. We'll talk about the pathophysiology, which is the main cause of our presentation today. And then we'll describe few types. And then later on, we'll come back and then we'll come and describe the symptoms. And then we talk about the surgical management. Now, for definition, as it stands right now, hemorrhoids do not have a definite, what do you call it, definition for it. We don't really have a concrete definition for hemorrhoids. Now, there are some anal cushions around the anal canal which are highly vascularized, discrete submucosal masses consisting of blood vessels, smooth muscles. The smooth muscles within these cushions are called the tragus muscles, and then there's some elastic connective tissues that are found around the anal canal. So symptomatic enlargement and displacement of these cushions is what we termed hemorrhoidal diseases. So that is what has now come to be accepted as, the definition for hemorrhoidal diseases. Now, with respect to the epidemiology, we don't have any exact prevalence. However, uh, this is because most people actually fail to present to the hospitals for us to get exact records of these diseases because it is around the perineal regions. A lot of people feel shy to report about it. So the exact prevalence is really quite difficult to come by. However, we know that previous studies have shown that it affects roughly about 4% of the world population. And approximately 1 million cases are diagnosed. These are statistics from Italy and from the United States. About 1 million cases are diagnosed every year in Italy, which consists of about 2% of the total Italian population. The disease generally peaks between the ages of 40 to 65. However, it can be found at any age, group. 4 out of every 10 patients with hemorrhoidal diseases are going to be symptomatic, which means that it is really quite troublesome. And about 50% of people above the age of 50 would have had hemorrhoidal disease symptom at least for a period for at least once in their life. Now we are the same way the pathophysiology is also very poorly. The theory of varicose veins has been postulated in the past to explain how hemorrhoids come, to what do you call it, to develop, and this varicose vein, theory postulates that hemorrhoids, were caused by varicose vein in the anal canal. However, this theory has now been discarded, and we don't accept it as being the pathophysiology behind the hemorrhoidal disease as of now. Neither are they dilated vascular channels, nor are they vascular hyperplasia. either. Now, today, the theory of the sliding inner canal seems to be the one that is widely accepted. This theory proposes that hemorrhoids or hemorrhoidal or hemorrhoid swellings develop when the supporting tissue of the inner cushions becomes weak. That's when they begins to what? Disintegrate and deteriorate. As you remember, I made mention that there are certain cushions around the inner canal that are made up of certain groups of blood vessels, connective tissues, and so on that constitute the inner cushions. Now, these inner cushions are being held by certain what they call a connective tissue or supporting tissue. The sliding what they call it theory or what they call it theory proposes that when the supporting tissue holding these inner what they call it cushions becomes weak or when it begins to disintegrate, that is when the swelling begins to form and it begins to what protrude through the inner canal. Two main mechanisms are involved in this what they call it theory. That is the theory of the supporting tissue becoming weak and then deteriorating. We have chronic straining. People who normally strain most of the time, and there are conditions that will make someone to strain most of the time. Straining normally causes vascular engulfment and dilatation of vessels within these inner cushions, stretching and disrupting the supporting connective tissue. Another mechanism is increasing in the resting inner canal pressure. These increase in the inner canal pressure can cause decreased venous return, which ends up causing venous engorgement, disruption of the supporting connective tissue, just like the chronic straining, what do you call it, mechanism. There are typically three major inner cushions. Therefore, we expect that when these cushions are beginning to deteriorate and beginning to and become engorged and sliding down, we expect generally to see about three major swellings around the inner canal causing these hemorrhoids. And these cushions generally are located in the right angle, the right anterior, right posterior, and the left lateral. If you take the clock, we normally see them at the 3 o'clock, the 7 o'clock, and the 11 o'clock positions when a patient is put in the supine and the legs raised up, that's in the latotomy position. So you will normally see it at the 3 o'clock, the 7 o'clock, and then the 9 o'clock positions. These are the normal locations of the inner cushions. Therefore, these are where these swellings generally originate from. There are various numbers of minor cushions lying between these three major cushions, and generally they are found between the 1 o'clock, 5 o'clock, and the 9 o'clock positions. Equally, because these are also smaller cushions, whenever the mechanism that is causing these inner cushions to get engorged, they also slightly begins to get engorged, and for that matter can also protrude outside the inner canal. The inner cushions of a patient with hemorrhoids show significant pathological changes. Whenever you do hemorrhoidectomy, or let's say you cut these inner swellings and you put it under the microscope by the pathologist, you will see some significant changes within these inner cushions. The first one is abnormal venous dilatations. The second one is the vascular thrombosis that you see within the blood vessels or the venous, what they call the channels within these cushions. There's degenerative processes in the collagen fibers and then the fibroelastic tissues within these connective tissues of the inner cushion. There is distortion and rupture of the anal subepithelial muscle. And then you will begin to see inflammatory changes within these inner cushions. And then finally, you will see increased resting inner canal pressure whenever you measure the inner canal pressure of people who normally develop these enlargement of the anal cushions. Therefore, looking at the where the inner cushions are located, both the major inner cushions and then the minor inner cushions, we can say that hemorrhoids generally can be divided into two depending on where they are originated from. We have broadly can divide them into two major types. We have the external hemorrhoids and then we have internal hemorrhoids, two major broad categories. The external hemorrhoids are generally located below the dentate line of the anal canal. They normally develop from ectoderm and are supplied by somatic nerve. This is very important because this actually constitutes what symptom this patient might come with if they happen to develop external hemorrhoids. The second one is the second type is the internal hemorrhoids, and these are normally located above the dentate line. Because the anal cushions that we describe are mostly situated around the 3, 7, and 11 o'clock position, these are where these, what they call the internal hemorrhoids generally generate from. So at the clock position, you will see them at these 3, 7, and 11 o'clock positions. And whenever we see these cushions at these positions, they are termed as primary, hemorrhoids. And then sometimes you can see those smaller ones that are normally located around the 1, 5, and the 9 o'clock position also becoming engorged, and they are generally classified as what? Secondary hemorrhoids. The internal hemorrhoids actually develop from what they call the endoderm, and hence they are supplied with what? With visceral nerves. We normally classify them according to degree of prolapse, that is according to how they slide down from the anal canal, exiting from the what? From the anal verge. And this classification is what we normally is what we normally term the Gallagher's classification, and it grades these internal hemorrhoids from grade 1 to grade 4. Generally, the grade 1 hemorrhoids are the ones that are within the anal, canal, just above the dentate line. They don't prolapse. The grade 2 ones are the ones that normally prolapse outside the anal canal. However, they normally, reduces spontaneously when the patient gets out of the toilet seat, or when they get up out of the squatting position. The grade 3 ones are the ones that normally protrude, they protrude or they prolapse from the anal canal. However, whenever the patient gets up, they don't go back by themselves, but you need to reduce them manually. And the 4th grade are the ones that cannot be reduced. There is a third type we call the mixed type, but this one is mostly not normally added to the 2 main categories. But there's a third type we call the mixed type. That's a combination of both the internal and the external hemorrhoids. Now, with respect to the symptoms, either the internal hemorrhoids or the external hemorrhoids, the patients normally comes with certain types of symptoms. The first and foremost is bleeding, which is the most common symptom with respect to hemorrhoids. And we normally see this bleeding mostly with patients who are presenting with internal hemorrhoids, irrespective of their grade. The most common presentation of patients having either the internal hemorrhoids or the mixed type of hemorrhoids is bleeding. And as you saw in the case presentation, it will mostly present with bleeding that normally occurs after defecation, and then the blood is mostly bright red. Sometimes they might have some clots associated with it. The second most common symptom that we normally see is local swelling. As you normally know, patients will present either with external hemorrhoid or with internal hemorrhoid that prolapse. They will come with some swelling around the anal canal. They might sometimes come with some discharge, and then sometimes these discharges will soil their underpanties and make them feel very, very uncomfortable. And with this discharge comes with its associated pruritus, so they will keep on, feeling itchy around their anal canal because of these discharge and these swellings that they have around the anal canal. Sometimes too, because the swellings, when they get a little bit quite engorged, when they defecate or when they ease themselves, the swelling, because it occupies the space around the anal canal, makes them feel as if they have not completely evacuated. So they feel, incomplete evacuation of their anal canal, and always feel like as if part of their, their stools is left in the anal canal or probably in the rectum, and also makes their rectum feel quite full. Now, pain, yes, this is one of the symptoms that we normally also see with patients presenting with hemorrhoids. And normally we see these, pain associated with these hemorrhoids, mostly with external hemorrhoids. That is one of their major presenting complaints. Now, with external hemorrhoids, most of them will not come with bleeding as such, but pain is their major presenting complaint. With respect to the internal hemorrhoids, generally they will not they will not have any pain, as you saw in the case presentation. The man has been bleeding for the past 2 years, but he never complained of any pain in the anal canal or with respect to the swellings that subsequently developed. Now, patients with internal hemorrhoids would begin to present with pain when the hemorrhoids becomes complicated. That is, when the hemorrhoids, persist, and progresses and becomes what complicated. And some of the complications that we normally see with these internal hemorrhoids are thrombosis, sometimes ulcerations, and so on and so forth. Or sometimes it can even be strangulated, causing ischemia. So these are generally the symptoms that these people would come with. Bleeding, we have local swelling, we have anal discharge, and then we have what you call pruritus, we have feeling of incompleteness with respect to the anal canal and the rectum when they move their bowel, and then they will be coming with pain, or those with internal hemorrhoids will be coming with pain when their hemorrhoids becomes complicated. So I will pause here, and then we'll give a chance for our other colleague to also come in and present. And then later on, we'll come back to come and talk about the surgical management of these hemorrhoids, also with respect to the case presentation that we did. Thank you very much.
Thank you so much, Dr. Nyama, for this insightful presentation. Dr. Mark, please, the floor is yours.
Hello and good afternoon. So my job is to present the pharmacy side of things, and many thanks to Dr. Nyama for a very excellent introduction and setting us up to continue with the presentation and then the knowledge that he has shared so far. I believe the last part of his presentation will also go well with the surgical component of it to close out the presentation. So my job is to discuss the pharmaceutical side of management of hemorrhoidal diseases. So if you're ready, we'll get going. So my presentation outline will talk about background of hemorrhoidal diseases, patient assessment by pharmacists in the pharmacy area. We did see a patient case that was presented by Dr. Nyama. So we'll look at some of the things that if that person had showed up in the pharmacy, you could ask or look into to see if you can help them before their situation got worse. We'll look at some treatment options, both pharmacological, non-pharmacological, and then we'll also look at some guidelines and then some other prescription medications that are available for treatment. We'll look at patient counseling, and then we will conclude. So this side has already been discussed by Dr. Nyama, so I will not spend too much time on it. We've all heard that hemorrhoids are swollen blood vessels in the lower rectum and also in the anus. Very common among our society. Those of you who work in community pharmacy or are in contact with patients at the pharmacy level, you notice a lot of people come by asking for remedies to treat their hemorrhoids. We also see lots of herbal and cars sitting everywhere. You go to the markets, you drive around and you see people, you hear people talking about all kinds of herbal remedies and all kinds of remedies to manage this condition, which tells us that it's a very common ailment. Most people are very embarrassed, like Doc said, to tell or to seek treatment. So they use the backdoor approach. So we do not have very good data on the actual incidence or prevalence of this medical condition. One of the key things that pharmacists need to do, especially before you start recommending any treatment for hemorrhoids, is to rule out any other conditions, gastrointestinal conditions such as GI bleed or cancer or anything like that. So before you start giving anybody medications, make sure you've done due diligence to rule out the key other causative factors or secondary causes, or what I call differential diagnosis. So Doc did mention potential causes of hemorrhoids. So this also, I will not spend too much time on it because of time. He did mention straining, pregnancy, obesity as another cause of it, prolonged sitting, whether on the toilet or for your work or occupational, possible rectal cancer, anal intercourse, other medical conditions such as inflammatory bowel disease or Crohn's disease. Inflammatory bowel disease, which includes Crohn's disease, and then ulcerative colitis. So he went over the different types of hemorrhoids, internal, external, and the mixed type. So I will also not go through that. He went over the assessment, the classifications as well. So let's go into patient assessment in the pharmacy. So you have a patient that shows up and tells you they have been told that they have piles or hemorrhoids. And when they go to the loo, they sometimes feel like they are straining, and then they've seen some bright red streaks of blood in the toilet roll. So just like the previous case that was discussed, you're in the pharmacy. What do you do? This patient is probably also in their 30s, very healthy looking, a very good professional, but they walk up to you and try to confide in you that, please, I'm facing this problem and it's very embarrassing, but I need some help. So what are some manifestations of hemorrhoids? To the first point, the degree of discomfort experienced by any patient will depend on the type of hemorrhoids and the extent and severity. I think Doc also pointed to that. So when they come to you, depending on how bad or severe their hemorrhoids are, their comfort level will show. Internal hemorrhoids lack nerves and are usually painless. So if they have internal hemorrhoids, typically they may not complain of any type of severe pain. But they will still complain of the other symptoms. Then bleeding hemorrhoids usually appear as bright red. So when you are doing that patient interview or taking that patient history, that is one of the questions you would ask. And you should be able to differentiate between, this is what will help you differentiate between an ulcer or a bleeding ulcer and hemorrhoids, because typically the hemorrhoids are there in the anal area, and then so any blood from there will be more like fresh blood that you see as bright red. But if it's up on maybe in the stomach or in the intestine somewhere else up on top, typically by the time it gets into the rectum or it starts coming out, you will see it more of like a coffee ground or darkish colored stool. So, and usually with hemorrhoids, it is usually used. The blood doesn't quite mix with the stools. You would typically see it like a streak of blood around the stool. So the patient does not bleed at other times aside from when they are defecating or when they are performing any activity in the anal area. So the internal tissues may enlarge and push below the dentate line. Doc also mentioned that, went through a whole section with pictures and everything. So for pharmacy, these are just questions you can ask to ascertain whether it's an internal or an external hemorrhoid, and also if it is protruding or not protruding, to help you at least decide if it's something you want to treat at your level or you want to be able to refer them to a physician. Typically, most patients who report to with hemorrhoids, after you've done your initial intervention, if after 7 days they still have symptoms, they have to be seen by a physician. But any patient that is bleeding typically has to be referred. Patients may describe the pharmacist, as a soft bit of tissue that shrinks back to normal after defecation, or requires the patient to manually push the tissue back into its normal position above the dentate line after bowel movement. And for a lot of people, the severe cases, these things do happen. So manifestations of hemorrhoids for patients who have permanent prolapse, typically these are things that will also happen. Patients with long-standing prolapse may discover that the tissue can no longer be replaced, that is pushed back into place. And typically that's a condition known as permanent prolapse. And so such cases also need to be referred to a physician or a surgeon for further management. Do not try to manage such conditions at your level. Usually when this happens, it interferes with the proper closure of the anal sphincter, and patient may notice fecal staining of the underwear. And they also experience irritation, and that can cause perianal dermatitis. So patients with prolapse or bleeding should be advised to seek a physician's care. And if they have rectal bleeding, or you should start thinking about cancer or anything as something more severe. So for external hemorrhoids, most patients will ask the pharmacist for assistance. Most people that will ask for your assistance may be experiencing any degree of discomfort from minor itch. So such symptoms will include minor itch, burning to severe pain. So they can come and you just say, usually I just experience itching down there. Nothing serious, but it's still uncomfortable. They can still sometimes experience burning pain or severe pain, depending on how severe the hemorrhoids are. I'll just talk about the last part. Okay, so when they occur, so when external hemorrhoids occur, they often no more than small skin tags hardly noticed by the patient. So they are usually very small, like we saw in those pictures, and sometimes they may not even be noticed by the patients or the clients. They can enlarge and then later on start causing severe pain or difficulty, or pain when after the patient cleanse. There's also something called thrombosis, which is induced by diarrhea, constipation, or physical activity such as riding a bicycle, when the bicycle seat places undue pressure on the anal side. So these are things that most patients will report to you, or you can ask or probe to be able to figure out how you can help these patients. So what are some of the things a pharmacist will need to consider to select an optimal management plan or treatment for somebody with hemorrhoids? One is your patient history. You must do a head-to-toe history of the patient. How old they are, any medical conditions, family history, genetics, lifestyle, social history, if they exercise, as many questions as you can ask them. So even though it's just hemorrhoids, you will still need to do a very comprehensive history, including if they have hypertension, diabetes, high cholesterol, thyroid diseases, and all of that stuff. Because there are so many things within the body that can contribute to this condition happening. Then also think about your available resources. What is available in your area? If you are in a rural area and there is no big hospital around, or there is no physician available that can see the patient, that also would dictate what type of treatment you can recommend for this patient. Then also the client or the patient, how educated are they, affordability, and a lot of other factors that you need to consider for this patient. And then your local and international evidence-based guidelines. What medicines are available at your end? What resources do you have? What is the healthcare system like, and all of that? These are all key things that we as pharmacists will need to look into before we make recommendations for a patient. What are your treatment objectives? Number one will be to eliminate any mechanical or local triggering factors, or reduce swelling or inflammation, reestablish optimal hemodynamic and microcirculatory conditions, especially in the anal area or in the rectum, prevent complications and side effects from treatment, prevent and reduce prolapse, making sure that the patient's condition is, stays away from relapse prevent or reduce relapse, or making sure the patient is able to go for a while without having relapse or coming back with hemorrhoidal attacks or acute attacks. So one of the good things about hemorrhoids is the fact that there are a lot of evidence-based guidelines and clinical resources that will help us properly manage these patients. Sorry. So some of the resources available to us: textbooks. Medscape is a very good source. It has a lot of good information. American Gastroenterological Association, the American Society of Colon and Rectal Surgeons, American College of Gastroenterology, and the World Society for Emergency Surgery, and American Association for Surgery of Trauma, and then other national and global societies. I believe Ghana also has a society or one of the associations that makes recommendations on treatment and management of these conditions. So what are some non-drug options for our patients? So first-line conservative treatment of hemorrhoids usually recommend using a high fiber diet, so 25 to 35 grams per day. That is one of the recommendations. The next few slides, I will share some information about some of the some diets and their how much content, the fiber content they have in them. And then also you can do fiber supplementation, which is like a medication that can provide fiber for the patient. So fiber supplementation decreases bleeding of hemorrhoids by about 50% and improves overall symptoms. So that is another thing that can be prescribed for your patients. That's aside from their diet, you can also supplement with fiber. And then there's also the recommendation to increase water intake to soften the stools or provide bulk and then make them easier to pass through the anus. So basically limit constipation. And then also warm water or sitz baths. So this is like sitting in warm bath for about 10 to 15 minutes, 3 times a day. They call it sitz baths. It also suits the area, helps manage inflammation and also reduces pain for these patients. And then you can also try stool softeners, medications that will soften the stool and make it easy for the stool to pass through the rectum and the anus. So the other thing is to advise patients to wash well with soap and water, and then following each bowel movement. And then instead of rather rubbing with tissue or tea roll or anything, it is better to blot the area. So it's like you're making this patches rather than going like this. So that is one of the counseling points or management tips that you need to give to your patients. And then giving patients a chart with fiber content of common foods that may help them increase their intake. And I have to say that some of the foods that are on this list may not be available in Ghana, but when you look at it, a lot of things that we do not know that actually contain fiber do contain fiber. So raspberries, pear, so just our avocado, apple with the skin. You get about 4.5 grams of fiber from it. Raspberries, 8 grams. Pear, 5.5 grams. Banana, good old banana. Orange as well, you get fiber. Strawberries, you get fiber from them. And then what about vegetables? So the first one was the fruits. The next one is vegetables. So your green peas, boiled broccoli, all of these you get fiber from them. With green peas, boiled green peas, you get 9 total grams of fiber. Broccoli, 5 grams. Turnip greens, Brussels sprouts, potato with the skin, you get 4 grams. Sweet corn, you get about 4 grams as well. Cauliflower, carrot, the raw carrots, you get 1.5 grams from it. So these are recommendations you can give to your patients, because usually they come every day asking, okay, you're telling me to eat food that is rich in fiber. What are those foods? So this can be a resource for you to make your recommendations to the patients. What about grains? So spaghetti, you get 6 grams, whole or wheat, barley, bran flakes, so your corn flakes and all of that. You get some fiber from it. Quinoa, oat bran, oatmeal, popcorn. So good old popcorn. You also get 3.5 grams of fiber. Brown rice, you get some bread, whole wheat, 2 grams of fiber, and then bread, rye bread as well. So there are a lot of options for these people. What about nuts, legumes, and seeds? So peas, you get 16 grams of fiber from the split peas. Lentils and boiled lentils, you get 15 grams. Black beans, 15 grams. Cannelli, 13. That I have not seen in Ghana. So chia seeds, 10 grams of fiber. Almonds, 3.5. Pistachios, and then sunflower kernels. All of these are common recommended foods that will help with hemorrhoids for people. What about pharmacological management? So a quick summary of the pharmacological agents that can be used. So there are multiple topical over-the-counter hemorrhoidal remedies. These may provide temporary relief. So that is the catchword here. So they do not cure your hemorrhoids. So the over-the-counter remedies do not cure hemorrhoids, but they do provide symptomatic relief temporarily, and they have not been studied for effectiveness or safety long-term. So typically, you just use them for a short term. They are recommended for short-term use. But among these, so some of the examples are astringents, which include witch hazel, the protectants, so your cocoa butter, hard fat, lanolin, mineral oil, petrolatum, topical starch, glycerin. These may be used internally or externally. So there are quite a lot of, and then there's also decongestants. The only widely used agent is phenylephrine. And then, of course, your steroids. So hydrocortisone is one of those commonly that used medication that you find in the over-the-counter topical hemorrhoidal products. And then there are topical anesthetics as well. And then also oral and oral pain medications that you can take, like paracetamol or brufen, to help with the pain. So most of the over-the-counter hemorrhoidal preparations combine 2 or more of the agents that I've listed up here. So typically you find them in combination products to help with temporary relief of the symptoms. So basically, what do protectants do? They are very useful due to the ability to form protective coating over the skin that prevents tissues from drying out. So they are very good agents that support anybody that has hemorrhoids, they protect the irritated areas. They will relieve burning and the skin irritation that will come when they are not around. And then they also protect the inflamed, irritated anorectal areas from abrasion and pain during bowel movement. So these are very key ingredients in the medicines that are used for symptomatic relief. They also protect the inflamed perianal skin. So they are applied after each bowel movement as needed, up to 6 times a day. So this is another. So people come and they ask, how often can I use this? So with the protectants, up to 6 times a day they can be applied, and then the key counseling point is it should be applied after each bowel movement. The local anesthetics, now those ones we know they are not appropriate for internal use because the mucosal lining of the rectum does not contain sensory fibers. So typically they are more indicated for the external use. And so because they are not indicated for internal, you will not find local anesthetics in our suppositories or ointment that are supposed to be used for internal hemorrhoids. They are, however, found in our external creams, gels, ointments, and wipes. So they relieve pain, they relieve itching, soreness, burning, irritation, and discomfort. They at least can numb the area a little bit and then help with symptomatic relief. So the last point is the different options we have. So your benzocaine, lidocaine, diclonine, and tetracaine. These can be applied up to 6 times a day, but pramoxine can only be applied up to 5 times a day. And then also dibucaine 3 to 4 times daily. So for products that contain dibucaine, they should not go above 4 times a day. But your lidocaine, tetracaine, benzocaine, you can go up to 6 times daily. One of the things to watch out for in patients that you prescribe local anesthetics for is to check for allergies. Always ask them if they're allergic to any of those things, because people do react to them. Then your vasoconstrictors, only one is phenylephrine. The key take-home points from phenylephrine is the fact that it contracts blood vessels, underlying tissues where they are applied to temporarily reduce the swelling associated with the irritated hemorrhoidal tissues. So this is also in combination with other medications. But the key thing is it should not be recommended for patients with heart disease. Also, you shouldn't recommend it for people with hypertension or thyroid disease or diabetes, and those who have prostate enlargement who take medication for it. Let me see. Yeah. So then, what about, so for OTC therapy, before you start even giving medications to anyone, one of the first things you should check is if there are any contraindications. So typically for pregnant women or people who are pregnant, we should cautiously recommend OTC therapies for them, because for especially those that can be inserted, these can be absorbed and then they could become toxic to the fetus. So typically, what we do recommend for pregnant women is to use the one that can be applied topically externally. Those typically may not be absorbed or may not be absorbed in quantities or concentrations that can affect the fetus. So also, if the patient has prolapse, that especially the one that they have to push back in, then OTC therapy is contraindicated. If they have any type of rectal bleeding, no OTC therapy. And then if they are less than 12 years old, consult a physician or at least talk to somebody before, but ideally you should not give OTC therapy to less than 12-year-olds. Or you've done OTC for the first 7 days, and then they still have the condition, they still have symptoms, they're still coming back, you should refer them. So there's a 7-day rule regarding self-therapy, and after that, they should be referred to a physician. So that is those are the tips about contraindications for use of OTC antihemorrhoidal therapy. So these are your options. These are some examples of the treatment options that we have for OTC. So hemorrhoidal ointment, pramoxine, mineral oil, zinc, rectal, phenylephrine witch hazel combination called preparation H cooling gel, phenylephrine cocoa butter rectal, preparation H suppository, phenylephrine, pramoxine, glycerin, petrolactum, general rectal, also called preparation H cream, maximum strength pain relief. And then there's lidocaine rectal called LMX5, pramoxine alone called fleet pain relief, proctoform foam, etc. And then also hydrocortisone topical slash pramoxine topical, proctoform HC, a very common one, analpram E, analpram HC, and then epiform proctocort. So there are so many options. There's also the starch suppository, and then benzocaine and then lidocaine, hydrocortisone combination. So these are some of the common treatment options that we find over the counter for management of hemorrhoids. Then what about prescriptions? So there are some prescription-only items, including nitroglycerin and nifedipine. Nitroglycerin comes as a 0.4% ointment that can decrease your rectal pain caused by a thrombosed or hemorrhoids. So usually it's commonly used for anal fissures, but whenever you have thrombosed hemorrhoids, nitroglycerin topical is one of the options that we use. The other one is nifedipine, which we compound in the pharmacy because there is no commercially available topical nifedipine. The other option in rare cases is Botox injection, which is injected into the anal sphincter to decrease pain of the thrombosed external hemorrhoids. So aside from these, what else do we have available? So in the American Academy of Family Physicians guideline in 2018, they do mention that supplements containing bioflavonoids, for example, hydrosmin, diosmin, hesperidine, rutosides, are commonly used in other parts of the world for symptomatic relief of hemorrhoids. So bioflavonoids may decrease bleeding, pruritus, which is itching, and fecal leakage, as well as lead to overall symptom improvement. So basically, these are other options that have been tried and tested, and it is known that they work. No, I'm doing something, so you're going to finish. Or you can pass the other side. So, sorry, yep. So they decrease bleeding, pruritus, and then fecal leakage. These have been studied widely now. Previously, we didn't have enough information about them or sufficient data to vouch for their efficacy, but now we have so many studies that show that they do work. So how about, does any other guideline or any global society mention them again? Yes, to the American Society of Colon and Rectal Surgeons clinical practice guidelines also mention that these medications can be used for hemorrhoids. So they provide evidence that for acute and chronic hemorrhoidal diseases, phlebotomics are a heterogeneous class of drugs that can be used. And then even though we do not know their true, or we do not have a very well established, or we do not have very well established information about their true mechanism, typically what we have, they have been found to strengthen blood vessel walls, which are associated with hemorrhoids, increasing venous tone and lymphatic drainage, and then normalizing capillary permeability. These are some of the things that will cause the swelling or inflammation within the rectal area, and then leading to hemorrhoids. So in a Cochrane review of 24 randomized controlled trials with a total of about 2,300 participants, comparing that with intervention using phlebotomics and control. The phlebotomics demonstrated a statistically significant beneficial effect for the outcomes. So they were looking at bleeding, itching, discharge and leakage anally, and then the overall symptom improvement. And I realized that overall, there were significant beneficial effects using the phlebotomics over control. And this was a study by Pereira and then Loyolitsa and friends. So there is a lot of evidence-based, randomized controlled trials that show that the phlebotomics are more like the mainstay in the management of acute and then the chronic diseases or hemorrhoidal diseases. Then, is there anything else? Yeah, so in another study by Alonso and friends, which is also a meta-analysis of, so this was another review. So meta-analysis of 14 randomized controlled trials that compare the flavonoids, diosmin, the micronized purified flavonoid fraction, and rutosize with placebo or no therapy in patients with symptomatic hemorrhoids, which is about 1,500 patients. They found that the flavonoids were noted to have beneficial effect on bleeding, itching, and recurrence of hemorrhoids. So it shows you that now we have so much evidence out there that the flavonoids and the micronized purified flavonoid fractions do give you enough, what do you call it? They help manage the condition. They give you enough relief from all the symptoms that are associated with hemorrhoids. So based on that, we have one of those medicines in Ghana approved by the FDA for the management of recurrent and acute and then recurrent hemorrhoidal disease. It is called diosmin, and the dose is 500 milligrams. Depending on the severity, you may need about 6. It's usually just about a 7-day treatment. You do 6 tablets for 3 days and then 4 tablets for 4 days, and that has been shown to bring relief of all the typical symptomatic manifestations of hemorrhoids. So they are indicated for the management of acute and recurrent hemorrhoidal disease. Diosmin reduces inflammation. It reduces pericapillary permeability and an increase in the capillary resistance to blood extravasation. So it doesn't allow blood to leak out into the intestinium. It also provides complete efficacy in acute attacks, which is it provides complete relief from bleeding, helps with pain, and then also with the itching, and then also significantly will reduce the duration and intensity of an attack compared with previous attacks. And plus, aside from that, it also has very good safety profile. So it is very well tolerated from all the patients we've given them to, and then also the data that we reviewed, it has a very favorable safety profile. So based on that, what about for pharmacists? What are we supposed to do in terms of counseling for our patients? So I'll just go over this one quickly. I think this is the last but one slide. Key thing is stool softness. So for anybody that has hemorrhoids, one of the key causative things, or one of the things that will lead to hemorrhoids is constipation. Stool softness are very safe, very few side effects, very good safety profiles. So we should recommend them aside, in addition to all the other things, for number one, especially. But if the patient does not have a problem with constipation, you do not need to suggest a stool softener. Regular exercise is another one. They should exercise. Most people that have hemorrhoids, they do not want to exercise, but exercise has been shown to reduce recurrence and also help manage the condition. High fiber diet is another one. I've shared a lot of slides on the diets. They should be drinking plenty of fluids. They should avoid straining with bowel movements, avoid sitting for long periods of time. They should take their medicines as prescribed. They shouldn't just take 1 or 2, and then once symptoms start resolving, they put the rest aside. So they should complete their therapies. And then also promptly report any unusual symptoms during treatment, and then observe the 7-day rule. They should not be shy about the condition because complications do happen, like Doc mentioned, if you do not manage the condition well. They should avoid consumption of stimulating drinks, such as coffee, tea, if those have been implicated in making their condition worse. They should not drink alcohol, and then also minimize the use of spices. And then finally, they should pay great care to personal hygiene and the daily habits. Avoid smoking and sedentary lifestyles. So to end it all, hemorrhoids are very disabling for our patients, and recurrent attacks are usually very frequent. But there are therapies that can be used. The inflammation associated with acute crisis can lead to a lot of pain and bleeding. Global guidelines do recommend diosmin in addition to the non-pharmacological therapies. and also your therapies that will help with the management of the symptoms. But we all know that with the OTC medications, they are not indicated for long-term management. So when that, we should always counsel patients about that, and then also make recommendations for medicines that can help keep the patients out of trouble, minimize recurrence, and also manage acute conditions or acute hemorrhoidal attacks. So it's important for pharmacists to identify clients that can be treated at the pharmacy level and those that need referral. Pharmacists will need to always also sharpen their knowledge and know the current guidelines in the management of hemorrhoids. And then pharmacists' interventions play a major role because typically most of the patients who have hemorrhoids will show up at your door first before even going to the doctor. So we should be sharp, and then we should make sure that whatever interventions we make or recommendations we give go a long way to optimize the care for our patients. So thank you, and then I'll be on standby for questions.
Thank you so much, Dr. Mark, for this insightful presentation and very detailed too. Thank you so much. So I kindly ask anyone who has a question to please type it in the chat box. Our facilitators will be glad to answer them after this session. Thank you. So we give Dr. Nyama the floor to conclude this session with his part. Hi, Dr. Nyama. Please, we can't hear you. Kindly unmute your speaker, your microphone. Yes.
Sorry. Yes. Sorry once again, and thank you very much. Let me say a very big thanks to Dr. Mark for his detailed presentation on the pharmacological treatment of hemorrhoidal diseases. Very insightful. I'll be talking about mostly the surgical aspect of the management of hemorrhoidal diseases. But let me just recap a few things that he made mention of, which are really very, very important. First and foremost, I would want to say that the diagnosis of hemorrhoids, it's purely clinical, which means that we diagnose hemorrhoids based on the history and the physical examination. So yes, you may get a story that might mimic what might be a hemorrhoid, but it might not be a hemorrhoid. So one, you need to take the history very, very well, and you need to also physically examine the patient to arrive at your diagnosis. It doesn't end there. Even after physical examination, when you have diagnosed the patient with hemorrhoids, there are several instances where these hemorrhoids may have been provoked by an underlying condition within the anal canal or above the anal canal, that's somewhere within the rectum or the lower part of the large bowel. Therefore, whenever you diagnose any patient physically with hemorrhoids, please make sure that there is no other underlying condition within the anal canal or the rectum, which means that yes, you may do your physical examination, yes, you may see some prolapsed hemorrhoids, or you may palpate a hemorrhoid in the anal canal, but please, you may have to investigate every patient presenting with symptoms of hemorrhoids to make sure that there's no any underlying condition for that particular symptom. And we normally do this using the anoscope or using the proctoscope to look into the anal canal and the lower part of the rectum to be sure there are no other condition there. Or sometimes we do what we call proctosigmoidoscopy or a full colonoscopy to be sure that there's no any underlying condition that could present just like hemorrhoids. Having said that, as Dr. Mark said, the treatment of hemorrhoid is basically based on three modalities. We have dietary and lifestyle modification, we have the non-psychological approach, and we have the non-surgical approach, and we have the surgical approach. Doc has done a very good presentation on both the dietary and the lifestyle modification and the non-surgical approach. I will not be wasting so much time on them. However, what I want to say is that treatment of hemorrhoids is based on a combination of these three modalities. We generally do not use just a single modality to treat any hemorrhoid. Based on the presenting complaints, based on the degree of the hemorrhoid, and also based on other comorbidities that the patient might present with, we choose a combination of either the dietary and lifestyle, the non-surgical, or the surgical approach to treat this disease. Now, the next thing I want to talk about is the surgical approach. Now, the surgical approach generally is divided into two groups. We have what we call the office-based or the minimal procedures, and we have what we call hemorrhoidectomies. That is, excising these swellings that are found around the anal cushions. So we start with the office-based approach. Generally, they are the first line of treatment when it comes to our surgical, armamentum. When the patient presents with hemorrhoids and we diagnose these patients with hemorrhoids, generally our first line of approach is to use one of the office-based approach, which is one of the minimal procedures. Normally, we recommend these procedures for patients who normally present with grade 1, that is, an internal hemorrhoid that is not prolapsing, or a prolapsing hemorrhoid that can be reduced spontaneously. Sometimes some patients with grade 3 hemorrhoids do also benefit a lot from these office procedures. Now, these methods mostly induce necrosis. That is the general effect of all the office-based procedures. They generally induce necrosis. They induce scarring and fixation of the hemorrhoids to the underlying tissue. There are several of them. I'll be mentioning their names to you. I won't go much into details of them, but almost all of them induce the same effect, that they induce necrosis, scarring, and fixation of these hemorrhoid swellings to the underlying condition, and for that matter, a good relief for our patients. Now, these are some of the office-based procedures that I was mentioned. The first one is the elastic band ligation, which generally we do quite widely in Ghana here. Now, we do this using a certain special, apparatus we call the band ligation, what they call a gun, that we normally, it's like shaped like a gun, and it has this rubber band at the end. So you position your patient either in the same position, or either in the the knee knee chest position, and then you identify these hemorrhoids, the swellings, where they are, based on the clock times that I gave you, and then you fix the tip of these rubber band gun on any of the swelling that you want to band. And then you connect the gun to a suction machine, and the suction machine has to be very good. So once you apply the tip of the gun to the hemorrhoidal swelling, then you apply your suction. So the suction sucks the prolapsed hemorrhoid cushion into the gun, and then after that, when you fire, it fires the band, and the band goes and then holds the neck of the swelling, and then it leaves it there. So with time, this band begins to cause ischemia, strangulation, and then finally necrosis and the sloughing of this hemorrhoid cushion. So it causes a very small wound over there, which generally heals spontaneously and then causes scarring. The next one is injection sclerotherapy, which we use different medications for doing this injection sclerotherapy. All these ones are also done as office-based. It causes scarring and subsequent fixation to the mucosa. And then we use sclerosant like the phenol, the quinine, urea, and then sodium morphine. Generally, we use the phenol most widely in Ghana here for doing the injection sclerotherapy. Here too, we inject our what they call it as our sclerosant into an injection, into a syringe. We position our patient, we identify the swelling, and then we go into the what they call it, any of these hemorrhoidal swellings, and we inject slowly these sclerosant, what do you call it, medicine into the hemorrhoid cushion, and then we leave it there, and then the patient goes home, and within a short period of time, it causes these what they call scarring and fixation of the swelling, causing reduction of the swelling, and for that matter, what do you call it, reduction in the size of the swelling, and then a good relief. The third one is the infrared photocoagulation, which generally is not available in Ghana here. This also causes coagulation of the tissues or the proteins within the hemorrhoidal cushion, and evaporates water from the cells, causing the tissues to become necrotic, and therefore becoming dead, sloughing off, and then causing fixation and scarring. The other one is the bicap electrocoagulation, which is also not available, and then the final one is the cryotherapy. All these can be done at the office or as outpatient day cases that does not need admission. Now, the other surgical approach is the hemorrhoidectomy itself. Hemorrhoidectomy meaning that removal of the hemorrhoidal swellings. Now, we recommend this treatment not for every patient presenting with hemorrhoid disease. Normally, we recommend it for patients who present with very advanced case of hemorrhoid disease, generally the third group and the fourth grade hemorrhoids, or those who present with complications, and some of the complications are thrombosis, as we mentioned earlier on, incarceration and strangulation, and sometimes ulcerations. When we see any of these complications, then we recommend hemorrhoidectomy. And then also patients who fail to improve after multiple applications of the non-operative methods, including both the pharmaceutical and the office-based methods. Should patients come with recurrence, then finally hemorrhoidectomy becomes our last option. Let me say that for the office-based procedures, the recurrence rate is extremely very, very high. A lot of the patients will need repetitive office-based, interventions before finally they're able to have a good relief. Some of them might have it multiple times, but then they'll still be coming back with recurrence. And therefore, when that one happens, then their final stop will be hemorrhoidectomy. It basically involves excision of the prolapse anal cushions. There are different methods that we use. We have the open hemorrhoidectomy. That means that we are excising. We position our patient in the lithotomy position, and then we see these swellings clearly, direct visualization, and then we use our electrocautery and our knives, and then we cut off these swellings, and then we ligate the vessels to prevent bleeding. And that's what we call the Mulligan-Morgan technique. And then we also have the closed method, which is the Ferguson technique. That one does not involve, complete cutting of the hemorrhoidal, cushion, but normally we go, submucosa to remove those cushions, those tissues that are within the swelling, protecting the overlying mucosa, and that's what we call the closed method or the Ferguson technique. And the third one is the stapling hemorrhoids, where we use a special stapling device that we insert at the anal canal. And then this stapling device sucks in these these hemorrhoidal cushions or the swellings into the stapling device, cuts it, and then at the same time, sutures it. So by the time you would finish with the stapling, hemorrhoidectomy, generally you do not leave any open wound over there, and that's the difference between the the open hemorrhoidectomy and the stapling hemorrhoidectomy. The stapling hemorrhoidectomy, we stapled the edges of the mucosa, therefore no open wound is left. The modern use of energy devices like the ligature and the harmonic scalpel has reduced complication rates of these hemorrhoid procedures. It does have quite a very high rate of complications, some of which are: number one, bleeding; number two, pain. A lot of these, almost all these hemorrhoidal procedures are associated with pain. Both the office and the open hemorrhoidectomies are both associated with pain. Therefore, Generally, after these procedures, patient will be experiencing some pain and they will need some very good analgesics for a period of time. And then also it could cause bleeding, some of the complications if you're not very careful, particularly with the most advanced, that is the grade 4 hemorrhoidectomy. If you are doing it, you're not very careful, you could cause anal stricture, for which I personally have operated not less than about 5 people within the last 2 years who have come with what? With anal stricture. That is, their anus got closed after they underwent hemorrhoidectomy elsewhere and they could not defecate. So we need now to take them back and do what we call anoplasty to open up their anus. So it is not a very, very easy procedure and has to be done very, very carefully. So the advantages of these surgical procedures is that it gives a very quick relief. That one, there's no doubt about it, because you are basically cutting off these swellings, and for that matter, patient gets a very, very quick relief of their symptoms. And also, if it is also done very well, it has a very low recurrence rate, because these swellings are the ones that you are cutting. So once you cut these swellings off, there's not going to be any inner cushions left for any recurrence to come back. Therefore, the what they call the recurrence rates are really very, very small. Sometimes, if the cushions are not cut very effectively and some parts of the cushions are left, that is when some of these swellings could come back. But if they are excised and they are excised completely, generally recurrence is a thing of the past. Some of the disadvantages, what I've just mentioned about severe pain, prolonged hospital stay. Sometimes they go into urinary retention because of pain. I've seen quite a number of patients who have gone through hemorrhoidectomy, and after that, after discharge, they will have to come back to the hospital with urinary, retention, because they are not able to urinate because of severe pain, bleeding, anal fecal impaction, and that's what I talked about. Those who have 3rd degree or 4th degree, and you are removing them, if you are not very careful and you do a circumferential removal, then you will end up with anal stricture or anal stenosis, therefore causing fecal impaction, and for that matter, patients resorting to anoplasty, unless they get a release. Sometimes too, if you are releasing this, if you are excising these cushions and you're not very careful and you go quite a little bit deep, then you will end up cutting into the anal sphincter muscles, and that could cause a very severe complication we call anal incontinence. Yes, it has happened, and we sometimes see these complications. So in short, that is the surgical approach that we use, both the office-based as a minimal, what they call approach procedures, and the final option, and that is the hemorrhoidectomy procedure that we do in Ghana. Here, we normally do a lot of the band ligation as the office procedure, followed by the sclerosant, what they call that sclerotherapy method that we use. So both the band ligation and the sclerotherapy are widely used in Ghana here. And then our last option, which is the open hemorrhoidectomy, that is the what they call it, the open method, is the one that we normally use as our last option. Sometimes a few patients who have a little bit of financial advantage could also have the stapling hemorrhoidectomy that we've done for a few patients. So in short, my take-home message are these. Number one, please, and this message also goes specifically for our pharmacy colleagues. Whenever anybody presents to you with symptoms of hemorrhoid, if they have not been to any hospital before, yes, please, let's give them some symptomatic relief, but do ask them to go to hospital so that they can be fully examined to determine whether indeed their symptoms is related to only hemorrhoids and hemorrhoids alone, and there's no any other condition. Because there are sometimes people will be moving from one place to the other with hemorrhoid, and finally when they come to us and we examine them, we find them to be having anal cancers and rectal cancers, which is really very, very bad. So let's make sure that they have full examination to confirm that they have hemorrhoids, and they undergo through any of these procedures that I talked about, that is the anoscope, the proctoscope, or the rectosigmoidoscopy, to be sure that there's no any underlying condition. The second, what they call it, take-home message I want to mention about is that, yes, we use a combination of these methods. Even with surgery, we still have to rely on dietary and lifestyle modifications, because if the underlying condition that is already predisposing the patient to the hemorrhoidal development is not dealt with and you do surgery, generally you do not get a good benefit from the surgical approach. Therefore, we combined it with both the dietary and the lifestyle changes, and then we also add some pharmaceutical, what you call medications, to get a good outcome. So a combination of all of them are used. So increase your fiber and your water intake, as Dr. Mark have already made mention of them. Rubber band ligation is considered the preferred choice as our first office-based treatment for both grade 1 and grade 2 hemorrhoids because of its effectiveness compared with other office-based procedures like the sclerotherapy. In Ghana here too, a lot of people do prefer doing the sclerotherapy, which is equally effective like the rubber banding. Excision, that is the open hemorrhoidectomy, is effective for treatment of the advanced stages, that is the grade 3 and grade 4, and those who have recurred multiple times, or the complicated ones, you will have to refer them for an open hemorrhoidectomy. And the final message that I want to say, as Dr. Mark made mention of, the macronized purified fibrinoid fraction had been clearly been been established as one of the most effective, pharmaceutical product out there for the treatment of hemorrhoid for all grades, starting from grade 1 up to grade 4. And sometimes, and not even sometimes, in almost all the time, for those who are even in advance, even when we are going to do surgery, post-operatively, we also put them on the macronized purified, flavonoid fractions, so that we can have a very good post-operative outcome. And in Ghana here, the only one that we all know about is the Daflon. So mostly after surgery, we put our patients on Daflon for a period of time so that they could have a very, very good outcome. Thank you very much.
Thank you so much, Dr. Nyama, for this detailed and insightful presentation on the surgical management of patients with hemorrhoids. Thank you, Dr. Mark, for bringing to light the pharmacy aspect and the pharmacy perspective. I think this session has been a very wonderful one, very informative and educative for both doctors and pharmacists in the management of your patients with hemorrhoidal disease, both in the hospital, surgically, and also in the pharmacy. So at this point, we would like to take our questions. So kindly put all your comments and questions in the chat box or the comment section below. And then the facilitators will be glad to answer them. So I think we will take the first question from Dawood Abubakari. And then the question reads, please, do hemorrhoids cause waist pains and sexual weakness in male as advertised by the herbal medicine sellers? So any of the facilitators could answer.
Well, let me start by saying that we have explained the pathophysiology of hemorrhoids, and I think it's really very clear that it has nothing to do with the reproductive organ. However, should the what do we call it? Should the disease progresses, particularly both males and females, because of the discomfort that they experience, certainly it will also affect your sexual life. And then sometimes also, if the procedure done, if you are going to do a hemorrhoidectomy, the procedure done is not done very well, then it could affect your sexual life. But it has no direct effect on someone having sexual weakness or anything, because the pathophysiology does not support that at all. I don't know whether Dr. Mark has anything to add. Thank you.
Doc, you said it right. You hit the nail right in the head. There is no direct linkage, unless maybe you have other comorbidities that in some ways may affect it. But especially in terms of waist pain, there is no direct link at all. So no. So hemorrhoids will typically not cause sexual weakness. There is no relation unless you have other underlying conditions or issues that may lead you to the sexual weakness. Thank you.
Okay, thank you, Dr. Mark and Dr. Nyama. So this from Samuel Tando. What is the correlation between anal sex and hemorrhoids? Post-hemorrhoidectomy complications in anal sex.
Well, I think when I was presenting and then I was talking about the pathophysiology, I spoke about two mechanisms. One of them is what they call is a sliding what they call theory, which states that the inner cushions loses their what they call the attachment what they call their supportive attachment what they call mechanism. And the second one is a what is a raised what they resting inner canal pressure. Now, uh, anal sex do result in all these what they call two pathophysiology mechanisms coming into play. The people who normally what they call it involve themselves in repetitive inner sex end up having a raised what they call it inner canal resting pressure. The second one is that when you're having this repetitive what they call it friction at the inner canal, it certainly will cause what they call it deterioration of these connective tissues that is holding these inner cushions to their base, and that is how they end up developing what they call it what they call it hemorrhoids, particularly people who are involved in this what they call it anal sex. Now, I think there was post-hemorrhoidectomy complications in anal. I don't get the question right, but if I would take the post-hemorrhoidectomy complications, those are the ones that I made mention about. Mostly we see bleeding, we see pain, we see what we call it anal stenosis or anal strictures, and so on and so forth. These are some of the complications that we normally see with respect to hemorrhoidectomy. Yes, thank you.
Okay, thank you. So this from CES Educate. So the question reads, do hemorrhoidal diseases manifest in the eyes or present with hyperpigmented lesions on the skin? We hear the public most of the time say they have piles which manifest in their eyes and or skin. That's a very interesting one.
Dr. Mark, if you could go first, this is something that we normally hear on the waves, on the airwaves, and then on our TV stations all the time.
Once again, I don't know of any direct relation to that, unless maybe during the straining from the constipation. But really, no. Pigmentation, no. Not that I know of. And then also the eye problems, no. Unless there's some type of straining somewhere. I doubt you can pick it up. Maybe you've seen something that I haven't seen.
No, not at all. You have rightly said it. I think the problem is coming from, the word that we used in the Akan language, and that is koko, representing hemorrhoid. This same terminology of cocoa is what is being used to refer to several skin and eye conditions. We use the same word cocoa to refer to so many of these skin and eye conditions. Therefore, most of the people or the what they call it the alternative health what they call it what they call it herbal treatment people, when they are making these pronouncements, use the word cocoa. So when they use the word cocoa, they think that what is happening around the anal canal, which is pure piles or hemorrhoids, are the same cocoa that actually manifests itself in our skins and in our eyes. They are not the same. They are absolutely not the same. Hemorrhoids are completely different conditions from any other eye condition or any other skin condition, and they are not the same, and they are not mostly not related at all. So when you hear somebody saying that, oh, the same cocoa that is occurring around the inner region is the same cocoa that is happening in our eyes and then our skin, it is completely false. Secondly, sometimes they also use other what they call it anorectal conditions and refer to them as the same cocoa. For example, warts, condyloma acuminata, all these things, they refer to them as cocoa, but they are not. Therefore, we have to be very, very careful about the terminology that we use, particularly in our Akan language, when we are referring to hemorrhoids. All cocoa are not hemorrhoids. Thank you.
Thank you, Dr. Nyama and Dr. Mark. So another question Why do patients experience difficulties in emptying their bowels after surgical procedure? So this is from Kujo Alfred.
Yes, Kujo, I think I have made mention of it. After surgical procedure, either the office procedure or the open procedure, hemorrhoidectomy that we do, patients do experience pain. There's no doubt about that. If you have a rubber banding, don't think it is painless. It is painful. Once they put that strip over there and ischemia and the necrosis is beginning to happen, you may experience some pain, particularly if the band is not placed very well and the band catches a little bit of your ectoderm that is around the anal verge. That is when it becomes very, 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 very painful. But if the band catches the what you call the mucosa above the dentate line, generally you might not feel any pain. However, when it begins to slough off and it begins to develop an ulcer, that is when probably maybe if some feces are falling off, it might scratch the surface of these ulcers that are developed at where the rubber bands were placed, and you might feel a little bit of pain. But generally, you will feel a little bit of, particularly when you are doing the sclerosant also as well, the injection of the sclerotherapy also as well. If you don't inject it very well into the inner cushion very well, and you inject it into the surrounding skin, that could also cause very, very severe pain. For the hemorrhoidectomy, it is very obvious, because we are slicing off these cushions and then we leave the wounds open. So certainly you are going to be experiencing pain. That is why patients who have had these surgical procedures do have pain. Thank you.
Okay, thank you, Dr. Nyama.
And
Can
then
we
let
take
me
the
let me also add that it
sure?
is the pain that is the pain that makes it difficult for them to move
Yes.
their bowel. When you are having pain in your anus, you wouldn't want to move your bowel at all, because you know that if the stools are falling off, it's going to cause you more pain. So for that matter, you hold on to yourself. So it's actually the pain that they experience that gives them that fear of moving
Mhm.
their bowel, and that's what makes them to become a little bit quite difficult moving. And then the more you prolong, or the more you postpone your defecation, the more painful it will become, because the more the stool stays in the rectum, the more the rectal wall will absorb more water from the stools, the more hard and bulky it will become, and for that matter, the more difficult it will be for you to what? For you to move your bowel. Therefore, whenever we are advising patients with hemorrhoids, we always tell them that, please, whenever you have the urge to defecate, do not postpone it. Because when you postpone it to the next time, it's going to cause you more problem during that time. So the moment you feel the urge, unless you're at a place where probably you might not be able to ease yourself because of probably maybe lack of available, what they call it, proper toileting facility or something of that nature, that you might not be able to move your bowel. But if you're at a place where you can easily move your bowel, the moment you feel the urge, that is when you have to do it. Even if you feel a little bit of pain, it's much better than you postponing it, because the next time that you postpone it to have it, the pain is going to be more severe. Thank you.
Okay, so the next question: does tranexamic acid have a role in the management of hemorrhoidal disease?
Dr. Mark?
Yes. So it depends on what is happening to the patient. If there is an active bleed where there's a need to stop the bleeding, typically most of the hemorrhoidal bleeding, you hardly will see blood flowing, and patients, maybe doc can attest to that. But so if you have an active bleed or a flow where you need to stop the bleeding and other measures have not been able to work, then typically you will see maybe a few doses of tranexamic acid being given to these patients, but not routinely. You wouldn't see a physician prescribe tranexamic acid routinely for a patient just to stop the bleeding from hemorrhoids. They will probably look at the other root causes and try to deal with them. Doc, please.
Yeah, thank you. I think you've said it all, and that's it. I mean, generally, we don't use tranexamic acid to treat patients with hemorrhoids, but if there is active bleeding, then certainly probably there might be for a short course of tranexamic acid to stop the acute bleeding, and then
Yes, yes.
that's right. That's it.
Right, thank you. So this from Samuel Tando: colon cancers and hemorrhoids kindly assist with the correlation and association in your practice. So this is to Dr. Nyama.
Yes, thank you very much for this question. And that's one of the take-home messages that I made mention of. Yes, hemorrhoids can, colorectal cancer can present like hemorrhoids. That is, patient can come to you with bleeding after defecation. And sometimes too, you could have the two coexisting in the same patient. That is, the patient will present with hemorrhoids, but up there could be a rectal or a colon cancer in there. Therefore, that is why we always say that whenever a patient presents with hemorrhoids, it might be just the tip of the iceberg. You need to investigate, examine, and investigate your patient to be sure that there's no any underlying condition as far as colorectal cancers are concerned, because the two can coexist. Thank you.
Okay, thank you. So the next question: any recommended medications for managing hemorrhoids in pregnancy?
So typically for pregnancy, we still look at the root causes, the history and everything, but for most people, you would just want to recommend something that can be used topically in the anus than anything that you need to insert. So no, anything that you have to insert is contraindicated, but um, um, if it's just to manage the symptoms, then you could use just any of the topical ones that you can use at the topically, not the ones that go internally.
Okay,
And I
thank you.
have to check. Yes, I have to check. So I think there will be a presentation on Daflon, but I think with the dosing for Daflon, you can do up to 6 tablets daily for the first 3 days, and then 4 tablets daily for the next 4 days. But there will be a presentation on it. I think after this one. Doc, do you have anything for your pregnant patients as well? Anything specific that you usually
Yes,
do for them?
you rightly said. Yes, sometimes we do present some of these topical, what do you call it, remedies, and at the same time, Daflon sometimes are also used. There is no clear, what they call it, I would say, evidence to show that Daflon is contraindicated in pregnancy, but the consensus is that if possible for the first trimester, if it can be avoided for the first trimester, you should avoid it and probably go with topicals. If from the second trimester and upwards, then probably Daflon can be used easily. So you're absolutely right. Thank you.
And then I wish to say that usually we steer the pregnant woman more to the dietary therapies than medications, because we want to make sure the babies are safe. So the fiber, stool softness typically will help. And then exercises and the sits bath helps them quite a lot, because at least that one is it's not medication that is going to be absorbed to affect the baby. Any other questions?
Okay. So please, can the phlebotropics be used across all grades of hemorrhoidal disease? So this from Bafo Jima Yeboah.
Yes, I believe they should be able to be used at all grades, especially the acute, because it's indicated for acute and then chronic management. It should be able to be used across all grades.
Thank you, Doc. And I think I also already mentioned that it's not only even for non-surgical methods, even with the surgical methods also, we use it as an adjunct. So both those who are going through surgery and those who are not going through surgery, irrespective of your age, the phlebotomics, that is the macronized, purified flavonoid fractions, can be used for all grades.
Okay, so what is your take on surgically managing hemorrhoids in pregnancy? This from Sam Frempong Shandoff.
Yes, I think this one, Dr. Mark just made mention of it. Generally, we try to stay away from surgery. if it occurs in pregnancy. And one thing about pregnancy-induced hemorrhoids is that majority of them after delivery, these hemorrhoids generally disappear. You know, a lot of them do very well without any treatment at all after they have delivered. So we try to stay away from surgery as much as we could. So should any hemorrhoid occur and become symptomatic during pregnancy, as that doc said, we use the topical agents, we use sit baths, and then sometimes we use these macronized, fibrinoid fractions to try and control the symptoms throughout the pregnancy until delivery. After delivery, you realize that most of the symptoms gradually, disappear, and then the patient becomes asymptomatic, and then sometimes even the swellings even disappear completely, or some of them may continue after delivery having these symptoms. That is when probably the surgery becomes a necessity. But during pregnancy itself, we try as much as possible to stay away from surgery. So mostly we don't do surgery for people, for pregnant women when they are having hemorrhoids during pregnancy. Thank you.
Okay, thank you for the feedback. So this from Ahmed Yusuf. Is diosmin safe in a hypertensive or heart failure patient with hemorrhoids?
I didn't see any information of contraindication in those patients, but I will confirm. I'll confirm. But in my research on diosmin, I didn't see anything that says they shouldn't be used in heart failure or hypertensive patients.
Okay, so there's another question. Please, can you explain further the 7-day rule? So this from Uzwame.
So basically, the guidelines do recommend that self-care for hemorrhoids typically should be about 7 days. So, and it's on the premise that when you have an acute hemorrhoidal attack or a hemorrhoidal problem that should be treated with any of the over-the-counter or symptomatic relief medications, usually within 7 days, your symptoms, you should have some symptom relief, or your symptoms should go away. So if within that period you are still experiencing issues, it is best to now move to the physician rather than saying that, well, let me just continue treating or retreat or something. There could be something underlying that initial over-the-counter therapy is not taken care of. And the more you wait, the more you may complicate your issue. So the guidelines are very straight about saying that you can self-treat for about 7 days, but beyond that, go to the physician. And that's why Doc also mentioned that, yes, as much as pharmacy, they come to us and then we can start something initially. Almost every person, especially first-timers, must go and see a physician for a thorough assessment to know the root cause, the underlying cause. And then that is where you also ascertain whether, is it okay for me to just continue with just symptomatic treatment, or there may be further management beyond the symptomatic OTC stuff. So, thank you.
Okay, thank you, Dr. Mark. Please, what are venotonics? Are they used only during the acute phase?
So I don't have a lot of information about the venotonics, but
All right, let me say a little bit about the venotonics. Now, these are medications that that are used to sort of treat patients who have peripheral venous insufficiency, and also those with varicose veins. In fact, the diosmins were initially actually, found to be effective, which is also a venotonic, were found to be effective in patients who were having varicose veins. So initially they were being used to treat varicose veins. So it was even later that they found out that they were equally effective in treating hemorrhoidal diseases. So yes, venotonics are medications that are used in treating patients who are having peripheral venous insufficiency, and then also with with varicose veins, what they normally do is that they cause a little bit of vasoconstriction within what they call it, within the smooth muscles inside the veins, therefore causing the veins to shrink a little, and thereby helping to push the blood in the veins forward. And that is the problem with varicose veins and then the venous insufficiency, because the valves within the deep veins are deficient. The body is not able to, or the limbs are not able to push the blood upwards effectively because of the deficient valvular disease. Therefore, when you give these venotonics, it sort of causes some little bit of vasoconstriction within the veins or within the smooth muscles of the veins, therefore shrinking them and helping to push these veins, this blood forward. And that was what diosmins were initially made for. And even up to now, still, we do recommend these diosmins, diosmins for patients who are having some of these conditions. Thank you.
Okay, thank you, Dr. Niyama, Dr. Mark. Please, can hemorrhoids undergo cancerous transformations?
Thank you for this question. Absolutely not. They are absolutely not related to cancer. However, like I said, hemorrhoids could coexist with other malignant anal and rectal cancers. Therefore, whenever anybody have hemorrhoids, don't just think it could be hemorrhoids alone. Let's re-examine them, or let's examine them to be sure there are no any other conditions underlining these hemorrhoids. But hemorrhoids per se does not have any risk associated with it being being transformed into malignancy whatsoever. Yes.
Okay, thank you. So there's another question. That thing that they usually say that cocoa water is hemorrhoids or power stained cocoa? Asking in relation to the question related to hemorrhoids manifesting in the eyes. Please enlighten.
Yes, and that's exactly what I said. That we have explained the pathophysiology of hemorrhoids, so we know what hemorrhoids are. Any other swelling that is different from what we have described is not hemorrhoid. There are other anorectal conditions that may protrude from the inner canal, just like what they call hemorrhoids, but they may not be hemorrhoids. And that's what Doug Bid mentioned about when he was talking about differential diagnosis. We have inner polyps, we have rectal polyps, we have anal cancers, we have what they call condyloma acuminata. That is what they call it, Verenia warts. All these growths can occur around the anal region and also from within the anal mucosa. Therefore, anything that is growing from the anal mucosa is not simply hemorrhoid. It could be hemorrhoid, but it could be something else. Now, the term cocoa is used to describe everything that is growing from the anal canal and around the anal region. Therefore, if a patient have rectal polyp, it is termed cocoa. If a patient have anal polyp, it is termed cocoa. If a patient have a polypoid anal cancer, it is termed cocoa. If a patient have polypoid anal, rectal cancer, it is termed cocoa. If a patient have anal wart, a big wart that is going from the anal canal, it is termed cocoa. But all these things are not hemorrhoids. Therefore, it becomes very, very, and that's the local term that we also use to describe hemorrhoid, that is piles. The other simple English word is what? Is piles. When you describe piles, anal polyps or rectal polyps or warts and so on, they are not piles. No. So piles is a simple English term for hemorrhoids, but our term cocoa actually refers to all these. And the same term is being used to describe other growths that we see in other parts of our body, including our skin and our eye. Therefore, that cocoa that probably maybe you may see growing in your eye or your skin, it's not the same cocoa that grows in your anus. Probably the term is a misnomer that probably we are using, interchangeably. But what we are referring to as hemorrhoids is what we have described, and the local term for it is cocoa, unfortunately.
Okay, thank you for the answer to this question. So, what is the most likely cause and treatment of hemorrhoids in pediatrics? And is there any correlation with worm infestation? This is from Emmanuel Abari.
So for pediatric patients, what we see often as the main cause of hemorrhoids is constipation. And for those of you who know children a lot or children habits, you notice that a lot of children have problems with constipation at an early age. So for them to have issues later on, typically it usually will be due to constipation. Some kids can go 5-6 days without having a bowel movement, and then they tend to push and then strain and all of that. Parents try to force them, and also for most pediatrics, the number one cause is constipation.
Okay, thank you.
I think Doc is on mute.
Yeah. In the pediatric cases, I think he made, and I think he made a correlation between.
Oh, we're losing you.
Hi, Dr. Nema, if you could kindly unmute.
Is it muted?
Yes, I think there's a challenge with Dr. Nema at his end. Hi, so before we get through with Dr. Nyama, I want to use some few minutes to the use of Daflon in your patients with hemorrhoidal disease. I'm sure we've all heard the micronized purified flavonoid fraction, which each of the facilitators have mentioned. So it comes with the brand name Daflon, which is produced by Servier. Okay, so what is the mode of action? 500 is has a natural composition of micronized diosmin. Okay, so it exerts its different actions on the venous circulation. So it has effect on the venous stone, on capillary leakage, and then it has an anti-inflammatory action, which reduces the release of mediators of inflammation by preventing leukocyte adherence. Okay. So this slide is very important because it differentiates Daflon from the others. So Daflon 500 is a unique formulation using micronization. So we say that Daflon has a micronized diosmin. So in addition to the diosmin, it has hesperidin and other flavonoids which potentiate the effect of the diosmin. Okay, so comparing Daflon, which is a micronized diosmin, to the non-micronized diosmin, we realize that there's an increase in the rate of absorption up to 58%. Okay, so these are all flavonoids or venotonics, as we saw in the previous slides by our facilitators. Okay, so they are venotonics. So daphlon is a micronized diosmin, differentiating it from phlebodia, which is a non-micronized diosmin. So the micronization simply means that we reduce the particle size to improve absorption for a rapid onset of action. Okay, so data shows that, or research and study shows that with daphlon, there's a 58% increase in the rate of absorption compared to the non-micronized diosmin on the market. Can we have the next slide? Okay, so what are the unique properties of daphlon 500? So I mentioned the micronization, which ensures its rapidity. So your patients will have a rapid onset of action, a rapid relief from their signs and symptoms. You realize that one of the main signs and symptoms that they present with is the pain and then the irritation and discomfort. You are relieving this rapidly because of the micronization of the diosmin in daphlon. And daphlon is purified, so it's a micronized purified flavonoid fraction. The purification enhances its quality. Okay, so we are giving you efficacy, we are giving you quality. And then the flavonoid content, which also potentiates the efficacy or the synergistic activity. As I mentioned, daphlon doesn't only have diosmin, it has 4 other flavonoids to potentiate the effect of the diosmin, which the other diosmin on the market doesn't have, which is just a plain diosmin. So how is daphlon taken? Okay, so daphlon is taking 6 tablets per day for 7 days. So to make it simple, we say daphlon has a dose as paracetamol. So it's 1 gram TDS for 7 days. So just like para, as simple as that. And then you can take 2 tablets daily as a maintenance dose for up to 2 months. Okay, so thank you so much for your time. I think Dr. Niyama is ready to take us through his the questions and the answers.
Yes, can you hear me?
Yes, it's very clear now.
Cases. I think the last question was in relation to pediatric cases and worm infestations. Certainly, as we all know, worm infestations in children present with a lot of symptoms. One of them is repetitive diarrhea. You know, when they have these worm infestations. So because they have this repetitive diarrhea, and then it causes them to strain. Certainly, that could account for them having what do we call it?
Hello, Dr. Niyama, please, your mic is muted. You can unmute yourself, please. Hi,
I think we can continue. Yeah, let's continue. Let's continue.
Sure.
Right.
So if you can have more questions, are there any more questions so that we wrap up? Okay, so another question from Emmanuel. Is the pathophysiology the same? Okay, I think we've answered this question. think Dr. Niama answered this question. Is the pathophysiology the same in pediatrics? And is there any correlation with worm infestation in that same age category? I think both Dr. Niama and Dr. Mark answered this question. Can we please have the next one? So, any benefits of topical nifedipine or nitroglycerin on hemorrhoids?
Yes, there is benefits to it. The only thing is we do not have them easily available in Ghana. For topical nifedipine, it has to be compounded in the pharmacy. And the nitroglycerin paste or the ointment it's very hard to get on the market, but they do have great benefits. They are recommended by the global guidelines for management of hemorrhoids.
Okay, thank you. I don't think there are any more questions. Okay, so this is a private question, private message question. So I think this will be our last question, and then we wrap up. So someone is asking, Dr. Michael, yeah, he's asking, are the herbal treatments like the Adum Cocoa also recommended for the management of hemorrhoids?
I think I'll leave this one for Dr. Mark to answer.
So I always say this. I believe in herbal treatments, but I'm also a clinician and an evidence-based person. And I believe that for every medication that you will use to treat somebody, you must have sufficient basis. You must have sufficient evidence that it works, it is safe, it has gone through all the rigorous testing processes to ensure that, yes, there'll be efficacy and then there'll be also patient safety. So I don't know exactly all the ingredients within the medicine you just mentioned, but for where I sit and the people I see, we have been seeing recently there's been a lot of patients coming in with liver and kidney issues from the use of herbal medications. I do engage some of these herbal remedy producers, and sometimes it's all about just the standards that are needed for us to be able to catch up with the rest of the world with regards to herbal medication therapy. So yes, I don't know if it will work because we don't have the evidence. From my presentation, I was able to show you that they tested medicines in X number of people, and this is what they found. So maybe we should start pushing for some of those things in our local remedies, and then we can make very sure recommendations that these work or they do not work. Thank you.
Yeah, I think what I wanted to add is that yes, herbal medications in its pure form, do work. After all, most of these conventional medications that we have are all herbal extracts. So no one can go and sit somewhere and say herbal medication doesn't work. No, it does work, and we believe in it. But the problem we have is that whenever a herbal product is being recommended for a particular disease, the question we ask ourselves is what is the ingredient, or what are the ingredients of that particular herbal product, and what are the dosages of those ingredients that we are taking in. I mean, those are some of the critical questions that I think we need to be asking ourselves when we are taking these herbal concoctions. If all these questions can be answered, and that requires critical research and studies, as Dr. Mark have already said, which in our part of the world here, unfortunately, we are failing to do. If you go to other parts of the world, they have really invested very much into herbal products, and they are really benefiting a lot. I think on our part over here, we have to take a little step behind and do proper research into our herbal extracts, what they contain, and then at what dosages we should be using them. If we are able to establish these facts, I can assure you that look, herbal preparation, usage will become as common and it becomes a routine, I would say, recommendation from doctors, in our orthodox what they call it medical practice as well. For all you know, most of these herbal preparations that they are using to treat hemorrhoids do contain some of these diosmins and these flavonoids, but we don't have any evidence to show that indeed they contain them. So I think that the onus is on us or upon those herbal what do you call it? What do you call it? Extract, what do you call it? Dealers to try and research and do a little bit of study into what the products contain. Give us those data, and then of course, everybody would understand, and this situation becomes a little bit easier for us. Thank you.
Right, and very well said. So I think that was the last question. At this point, we would want to take the final remarks from our facilitators. So, Dr. Nyama, if you could kindly give us your final remark as we close this presentation and session.
I think I want to go first. When the chief speaks, then everything ends.
Oh no, please. All right, no, please go ahead.
As you wish.
So I really just want to thank everyone for your attention. Also, thank you, Dr. Nyama, for making us mini surgeons because you've taught us a lot. We've all learned from you, and for our colleagues and everybody, let's keep doing the right things. Let's keep learning. And I think we'll go far. Many thanks to Xavier for the opportunity for us to share knowledge. So we hope that everybody learned something. And then I wish you a good night. And then also many thanks to Dr. Nyama. Once again, I salute you. Thank you.
Okay, thank you, Dr. Mark. Dr. Nyama, if you could kindly unmute. Yes, as we take your final remarks. Hi, Dr. Nyama. Please, I think your microphone is still muted. If you could kindly unmute for us to hear you. Hi, Dr. Nyama. Please, your microphone is muted. If you could unmute for us to hear you.
Hello, can you hear me?
Yes, it's back now. Yes.
Thank you very much. And sorry, the PC was having a little bit of problem. I do salute Dr. Mark for your presentation this evening. It has been wonderful, and I'm sure a lot of our pharmacists, our young doctors who joined us this evening would really benefit from the enormous information that you've given us. Thank you so much. My other thanks go to all the listeners who gathered around their PCs, their phones, and so on to listen to us this evening. I'm sure that the little information that we've shared would go a long way to to help you in your practice with respect to hemorrhoids and hemorrhoidal disease treatment. My other thanks go to Xavier, Maxine, all other guys who have actually collaborated and who has actually helped in making this presentation a success. Thank you all, and may God richly bless you all. Thank you very much.
Okay, thank you so much, everyone, and have a good night. Kindly take your post-test exam or quiz to earn your CPD points. Thank you, and see you some other time. Have a good night, everyone.